Thanks so much. And I'm conscious of time and giving us a little bit of time for discussion. So I won't have so much data, but more talking about treatment algorithms and how can I compete with that tractor and that chainsaw, Dr. Klempner? That's just so impressive. So I'm going to walk us through some cases based on what both Yelena, based on really, I suppose, primarily what Yelena has talked about today, and looking at some metastatic cases. So these are actual cases of mine from Cambridge. So the first case is a patient with a 59-year-old gentleman, like many of our patients, with a short history of dysphagia, who was diagnosed with a junctional adenocarcinoma, shown to be HER2 positive, MMR intact. And at that time, he had a CT and PET, which confirmed a T3N2 tumor. He had some mild medical comorbidities, but was generally fit and well. So kind of recapitulating what Sam has asked, what would you do for this patient? Would you go with FLOT? Would you go with cross neoadjuvant chemoradiotherapy? He's HER2 positive. Would you add trastuzumab to chemotherapy in the neoadjuvant setting? Or would you add chemoradiotherapy plus trastuzumab? Okay, so good to see. Actually, here we have a patient who is, because I think maybe it was esophageal cancer, we're having more patients treated with cross. Maybe that's after you showed the Checkmate 577 data, because we've had a bit of a switch up. And about a third of patients using FLOT. And so, for my preference here for this patient, if the margin is clear, and we've been discussing that in the side, I think that the risk of systemic disease is quite high for this patient because he's N2 at presentation. So I'd probably go for FLOT. I think there's nice questions here about whether we can add trastuzumab to chemotherapy or chemoradiotherapy, but we can't do that at this moment in time. We've had some studies looking at the addition of trastuzumab to FLOT. That would be Petrarca, and that did show an increased complete pathological response rate, but it was only 80 patients. So it wasn't a registrational trial. And we've also had a study, which was an RTOG study that added trastuzumab to cross-type chemoradiotherapy, and it showed no benefit. However, I don't think that means that HER2 tumors are necessarily radioresistant. They chose some patients in that study. They selected using FISH only, so they may not have been HER2 positive. And also the surgical quality control in that study could have been a little bit better. So I think we could still consider HER2 in the future. So at the moment, I think either A or B are great options. And for C and D, maybe we're not there yet. So we have the next slide, please. So what we did, well, at this point, this patient was in another hospital. They were treated with FLOT. They had surgery. And unfortunately, after surgery, they hadn't had a great response. They had 2 positive lymph nodes, so they were N1. And really sadly, they developed liver mets directly after surgery, and almost straight away went on chemotherapy and trastuzumab. And at their first scan, in fact, they developed progression. So that's quite unusual for chemotherapy and trastuzumab. We usually see response rates of about 50%. And you might consider that this patient was quite resistant to trastuzumab, and what would happen next. So the question for the audience is, what would you do next for this patient? So we're talking about our second line treatment in HER2 positive cancers after cisplatin and 5FU and trastuzumab. So is it start taxane chemotherapy with ramucirumab? He's just had a taxane with FLOT, really, hasn't he? Start irinotecan or FOLFIRI, start trastuzumab deruxtecan without a biopsy, or start trastuzumab deruxtecan only if the biopsy showed retained HER2 positivity. So I guess it depends on availability. This is a second line patient, and we have data to support trastuzumab deruxtecan in the second and third line setting. Certainly the randomized data is third line, but the license both in Europe and in the States is, I think it's, you can correct me, am I wrong? Is it available second line too in the States? Yes, it is. Thanks, Sam. So you do have a licensed second line. And so, but I guess, the efficacy is, do we need to do a biopsy? So we know that about a third of patients lose HER2 after trastuzumab, and this patient does not really suggested that he was particularly sensitive to trastuzumab. So I'll tell you what we did. So I actually think for this patient, if we didn't have trastuzumab deruxtecan, FOLFIRI or paclitaxel ramucirumab could be options. But what happened to this patient was, go to the next slide. So they had a biopsy and they had retained HER2 positivity, and they were treated with trastuzumab deruxtecan at that time. So I'm just going to review again what Yelena has already showed you about TDXD, because this is a new, or HER2, which is a new treatment that's available in the second and third line and guideline recommended for our patients. So it's an ADC. It's got a trastuzumab-like antibody linked to 8 molecules of deruxtecan, which is a potent topoisomerase inhibitor, a bit like irinotecan. And it's got some nice characteristics which allow diffusion of the chemotherapy out into the region of the tumor, thus targeting the non-HER2 positive cells. Because we know that even in HER2 positive patients with gastric cancer, even those who are strongly HER2 positive, there's lots of cells that are not HER2 positive. So it's really helpful to have that bystander effect, which has certainly been demonstrated in the lab. So we have 2 positive trials, Destiny Gastric 01, which was a randomized trial conducted in Asia that had response rates of around 40% in third line and a median survival of about a year, and also improved compared to taxane or chemotherapy in that setting. We also have a validation cohort in a non-Asian population, which was Destiny Gastric 02, about 80 patients, all of whom had a biopsy to show retained HER2 positivity. Same response rate, about 40%, and a median survival of about a year. So I think that we can be fairly confident if we biopsy our patients and they have retained HER2 positivity about the response rates. And I see Sam has made a question. Oh, he's talking about ctDNA. So we can come back to that. So that's TDXD. So this patient, can I have the next slide, please? This patient was started with TDXD, and surprisingly, given the fact that they had rocketed through chemotherapy and trastuzumab, had a great response. And so 1 year later, a little bit of weight loss was noted, but the cancer was still in remission on CT. We saw a little bit of a decline in the ejection fraction on imaging, on cardiac imaging. We started an ACE and a beta blocker, as you might do when we see a reduction in ejection fraction. But we saw a little bit of inflammatory change up in the top of the left lung. And you know what? A lot of these patients often have some inflammatory change in their lung if they've had an esophagectomy, because we've deflated the lung for surgery. So it's not unusual to see that. So what would you do next for this patient who's on TDXD? Question, do I use growth factors? Yes, I do, because I think I see a fair amount of neutropenia on TDXD. So what would you do next? Stop the treatment, hold the treatment, repeat the CT in a few weeks, stop the treatment altogether and start steroid, or continue? Yeah, so, and in fact, most people are doing as is recommended by the management for TDXD, which is temporarily stop, repeat the CT in a few weeks. Some are saying we should stop altogether, about 1 in 6 patients, and some are saying continue. And I would be a little bit concerned about continuing here, because we know that for about 2% of patients treated with TDXD, you can have a fatal ILD. But it's important to note that ILD overall is not common and fatal ILD is rare, but we do need to identify and manage it correctly. So what we did was, you can see the old changes up here in the left lung and then the new changes here. So we started up in the top left lung corner. And the next slide, please. So actually we held the TDXD and just out of an abundance of caution, we started prednisolone, because you do have the option to start prednisolone even for grade 1 ILD. And the patient went off to his house in France on holidays. And then he noticed in France that he was becoming symptomatic. He had not been symptomatic before, and returned to the UK, and we saw a repeat CT. What would we do next? So would you bring them into hospital, increase the steroid dose, around 1 milligram per kilogram of prednisolone, or restart treatment? So 60% taking the route of admit them to hospital, a third increasing the steroids. I think they're already getting a fair amount of steroids, and 7% saying get on with treatment. I think that my preference here would be to bring the patient into hospital, because I think that they've become symptomatic. So it's definitely a grade 2 now. The x-ray is looking worse, and it probably needs some further workup. Okay, so you can see here on the CTs, there's a pretty rapid deterioration in a month on the CT in terms of the ILD, but there could also be other processes going on. And that's really a really important question to ask, especially in these days of COVID. So We brought the patient into hospital, and just to highlight, it's really important for us to do a multidisciplinary workup when we see this type of toxicity. It's the same for immune checkpoint inhibitors. So this is what we've been doing for pembrolizumab and nivolumab for some years now. So infective workup for SARS and respiratory viruses were negative. Started methylpred IV, so that's increasing the steroids. Getting a bronchoscopy and BAL. Hadn't improved with methylpred, was a bit of a worry. And had a little bit of a transaminitis, so we couldn't use anti-TNF and started mycophenolate instead. And what turned out to be causing the worst shortness of breath was the patient also had PCP. So we need to be very careful when we're treating patients with steroids to look at other respiratory causes for deteriorations. And in fact, after we treated the PCP, we were able to reduce the steroids, wean the mycophenolate, and the patient made a gradual recovery after a couple of months. I will say that the patient actually continued to do really well off TDXD for 8 months before he progressed and started third-line treatment. So there we can see the recovery of the ILD from his lungs with the appropriate treatment. So that is why we need to identify it and treat it early so that patients can have subsequent lines of treatment. I think that's really important. So just to remember, it's rare, but to consider it in your differential. So this is a summary of the AEs that we might, the adverse events that we might expect when we're using TDXD in our patients in second line. There was a question about neutropenia. Neutropenia is common. And for patients who I'm concerned about the risk of neutropenia, sometimes I do use GCSF. Also, the most common toxicity is nausea. And usually that's mild. We tend to use standard antiemetics. And sometimes I use olanzapine for upper GI patients because I find it's really good for the appetite. And we've already summarized this, but this is to highlight the importance of multidisciplinary care when we're treating a patient with suspected ILD. Really, I'm led by my pulmonologist. He's great. I have a great relationship with him. And I also have a great relationship with my cardio-oncologist. So make friends with these guys in your hospital. We have the guidelines there for management of ILD. With grade 1, we can hold, and if the changes are resolved in a month, we can re-challenge. With grade 2, we should stop. And it's very likely to resolve if we treat it appropriately. I see a question here for, do I use 2 or 3 antiemetics? I will use ondansetron and aprepitant as well as steroids. And the question is, sometimes patients get brain mets. Do you like TDXD for HER2 positive patients with brain mets? Yes, indeed. And we expect to see responses, don't we? Because certainly in breast cancer, we see tremendous responses for TDXD with brain metastases. And so there's just a few comments here on management of TDXD in terms of neutropenia and left ventricular function decrease. But in the interest of time, I'll leave these here for your download and go on to the next case. The next case is more representing a HER2 negative MSS case, because I think Sam and Elena have discussed the MSI really nicely. A 72-year-old female presenting with very typical upper GI symptoms, epigastric pain and weight loss, and sadly diagnosed with metastatic disease at presentation. A few small comorbidities, but generally a good performance status. So we're talking about biomarkers. So these are the biomarkers that Elena discussed earlier for reinforcement. So what should we test? HER2 and PD-L1, HER2 and MMR, HER2, PD-L1 and MMR, TMB, or all of the above. Okay, so 2/3 of people go in for the HER2, PD-L1, and MMR. Totally agree. So these are the 3 most common biomarkers that we need to test right now. We may do Claudin in future, and all of the above. So, I mean, if you have access to NGS, why not? It's not available for everyone, but can give helpful information on resistance biomarkers or clinical trials in future. Okay, so this patient was HER2 negative, PD-L1 CPS of 3, MMR intact, and NGS was not done. So what would you do with this patient who is HER2 negative with a CPS score of 3? Just chemo, doublet, chemo triplet, chemo with immune checkpoint inhibitor, nivolumab or pembrolizumab, immune checkpoint inhibitor on its own, or trastuzumab, chemo and trastuzumab. Okay, so most people just go in for a platinum 5-FU doublet, which is the standard of care. A couple going for platinum 5-FU and taxane. Some going for the addition of immune checkpoint inhibitors. Maybe that's because the CPS score was 3. And I think that's pertinent to what Elena was discussing earlier. and some going for an immunotherapy monotherapy. I think in an MMR proficient patient, probably we do need some chemotherapy to avoid early progression. What we did for this patient, who we can't use PD-1 inhibitors in the UK or in Europe if the CPS score is less than 5, and the patient wanted to explore clinical trials. So she was screened for a trial of a chemotherapy and an anti-Claudin-1 or anti-Claudin 18.2 antibody, and treated on that because she had Claudin 18.2 expression. She had some nausea on the study and some hypoalbuminemia, and a good response after 2 cycles. We dropped the oxali after 4 months because she had neuropathy, and she stayed in a PR until 18 months when she had some progression in her liver. So what would you do next? She's been off oxaliplatin. She's on the trial. She's on 5-FU and a Claudin antibody or placebo, probably the Claudin antibody if she hasn't progressed for 18 months. So what would we do? Reintroduce oxali, stop treatment, do paclitaxel, stop treatment, start FOLFIRI, or do another clinical trial. Okay, so most people go in for paclitaxel and ramucirumab, which is the standard second-line option. I actually don't think any of these are the wrong option, and I'll hear from maybe Elena and Sam on this, but I think that we do sometimes reintroduce oxaliplatin after a break. We do also use irinotecan, and we always consider clinical trials for our patients. In fact, we don't have access to ramucirumab in the UK, so second line trials are standard for my patients. Okay, so just to discuss maybe very briefly where we are in terms of our treatment algorithms. So for advanced GEA, what we should be doing first is checking for MSI. And if they're MSI, we could consider first-line immune checkpoint inhibition only if that's available. It's not available everywhere. Or chemotherapy and immune checkpoint inhibitors. So in the UK and in Europe, we need to select using CPS scoring, so greater than 5 or greater than 10 for nivolumab and pembrolizumab, respectively. We check HER2, and patients can be treated with chemotherapy and trastuzumab plus or minus pembrolizumab, depending on approvals. And then we've got these other 2 really exciting biomarkers that we're exploring, including Claudin 18.2. And Elena showed you the results from Spotlight and GLOW, although we don't have approvals for this yet. And we also have FGFR2b, which is being explored in Fortitude 101 and 102, but we don't have positive results from those registration trials yet. So those are slightly more exploratory. But this is the direction of travel for upper GI cancers. So this is, in summary, what happened to this patient. We talked about a clinical trial, and she went on a novel immunotherapy trial of a TIGIT antibody and didn't have a prolonged response to that. We sent an NGS panel, and she had a ATM mutation, which is common in gastric cancer. And we explored PARP inhibitor and ATR trials, but there was none available for which she was eligible. So she started FOLFIRI, and patients with an ATM mutation might also be sensitive to irinotecan. She responded to that when her treatment is ongoing. So this is our treatment options in second line. For MSI, we can consider pembrolizumab, which is definitely approved by EMA and FDA. For the MSS patients, we have the option of chemotherapy alone, chemotherapy and ramucirumab, or ramucirumab monotherapy. And then we also have for HER2 positive patients, TDXD, or trastuzumab deruxtecan, which we've discussed in detail. In third line, the best evidence base is for trifluridine Tagrisso or Lonsurf, because there is a randomized trial. But we also use chemotherapy, maybe the chemotherapy which hasn't been used in second line. Can we have the next slide, please? And this was just to discuss some third line trials.